All right, well, welcome back. I appreciate you all coming back. I know it's afternoon and you're starting to get a little sleepy, so I appreciate you being here. We're going to talk about some other target improvement areas. Now, in our clinic, can everybody hear me okay without the mic?
Yes.
We have this, at RiverStone, we have this long conference room, and I do this all-staff meeting, which is, your 40 providers and all your staff. So, I have like 75, 80 people, and I make people use the microphone, and because if you're trying to talk that far back, you kind of sound like you're yelling, and nobody really needs to be yelled at. And the funny part is you get the people in the back row, and they sit back there the whole time, and then later I'll say, was that a good presenter? And they go, I couldn't hear a thing. It's like, that's a useful piece of information if you just gotta wave your hands. So now I just say, just please use the microphone. Okay, so some other target areas for improvement for us. Now, everybody here is on electronic health record. Is that a safe assumption? And yours probably works perfect, and all your doctors love it. And they don't want to go back to paper ever. But ours, on the other hand, we have some issues with our electronic health record, and we use ECW, if that's important to anybody. It's funny, I do a lot of interviews, and people come in, they tell me they use Epic, they use Centricity, they use ECW, and so, you kind of like, oh, ECW, and then you do the interviews, and they're like, oh, that's way better than ours, and that's way better than ours, and I'm like, I think it's kind of up for grabs. I think electronic health records are just electronic health records, and it's all new and getting better. And IT issues. So just like Megan talked about having providers that were the most skeptical, inviting them to the table and being part of that pilot project. Our poor IT department, honestly, it drove us crazy, and I'm pretty sure we drove them crazy. So what did we do? We invited them to the table and said, you've got to be part of this workflow improvement process. We invite you to the table, and let's figure this out, because that phone call saying, it's the circle of death on my screen, and I hate this. And it's a nurse, it's the front desk, it's a provider, it's everybody. I've got the circle of death. They don't even like hearing us use those words. We still do when they're not around, but it's the circle of death. And they got really tired of hearing about that and very frustrated because they're working very hard. They don't come to work to make our days more difficult. They're trying to help us help the patients, right? So we invite them to the table. One of the first things we did, and this was awesome, is we did hire a full-time, our IT department, ECW specialist. Now this person is a brilliant RN that used to work in the clinic. She actually used to have my position. She managed a clinic, and she works in the IT department. So you have a person that's very, very good with electronics, with computer, and our ECW. Her mind just works that way. And she works alongside our IT department, and they are brilliant. I mean, I could have a whole session on some of the brilliant things our IT department has done. And when they're in a room together, one's Nathan, one's Brianne, is the ECW specialist. I swear that the nurse translates for the IT person, and the IT person translates for the nurse. And that's what you need. You can't just have IT taking care of your health record and all the problems and trying to figure out how to improve it, because all we're doing is complaining back and forth. Doesn't get us anywhere, we're not moving forward. So that was truly one of the greatest things we did. One of the many, I could name quite a few things that Megan talked about that just made a huge difference. And then the creation of an ECW advisory group. And that's a group that meets on a consistent, regular basis, and they just talk about different issues, what's going on, what we need to do. There's some things you just need provider and nursing and front desk input. So you've got a variety of people at that table, a diverse group in that table, to just discuss and hash through some of those issues. And then the IS department themselves had a couple projects that they worked on. One is to quantify and category IS issues. So instead of the circle of death, I hate it, get down here, it's ruining my life and my patient's care, and we can't check people in at the front desk. It's like, why? What's going on? What were you doing? What happened? And just gather that information and figure out what the real problems were, instead of just getting in that, I'm complaining, it's your fault, and they're complaining it's all our fault, whatever. The other thing they did is a design of an experiment around the variation between users. Because as they started to categorize all this information, you know how it is when you start looking at data, you start seeing trends. It's like, okay, there are some trends here, and we're looking at all the different people's computer problems, and are there areas of the clinic maybe that the internet isn't as good? our South Clinic is the old end of the clinic. Is it not working as well? The biggest thing we found out, we had every type of laptop. We use laptops. Everybody, the providers and the nurses carry a laptop, all different kinds. Because IT was working so hard to find one that would work best, they would buy maybe like 2 or 3 of them. Well, that's not quite the one, so then the next one. So you can imagine how many different ones we had. Well, it just doesn't work because then they're all so different that it's really hard for IT and for everybody to stay trained and stay current. So we're all in the same laptop. I shouldn't say that. The providers are all on the same laptop and nursing staff are all on the same laptop. So when they talk about their computer, they're all talking the exact same thing. Okay? Another one was lack of consistent knowledge, training, and skill sets. And this is probably another one that everybody in this room can relate to. It's really hard when you have 50 staff and 40 providers and get them all on the same page and walk into a room and give this fabulous presentation to your MAs and your LPNs and your RNs and then walk away and say, they got it. They all got it. Well, we all know learning doesn't work like that. You start getting into some of these things, and we use a lot of Excel. And so we fired into it. Yeah, you can use Excel, you can do this. And the quiet ones in the room aren't telling you. They don't even know what Excel is. And then there's another group of them that they know, but they've never used it. And they really have no intention of ever using it in their life. They just do not. And so it's like, okay, back up, and do a lot of training and get everybody on the same page, which is just a constant thing. We implemented biannual Teams Work retreat. I'm going to give Megan the credit. She named it Teams Work, which I think is really clever. So twice a year, we close the clinic down for half a day. You all know that's a big deal too. If you're going to close your clinic down for half a day, which means then patients can't get in that day, just half a day, they can get in the afternoon. But if we close it down for half a day, we're going to use that time very, very wisely. What we don't do is take that time and just cram more training down their throat because they are trained out. And sometimes when I'm in front of them, I feel like that teacher on Charlie Brown, that wah, 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 and they're just going, please stop talking. So we try to bring in an outside presenter because they do hear a lot from Megan and I, for example, and we have brilliant things to share. But, they might want somebody else on the call. So we bring in speakers, real inspirational, team-building type speakers. We do some fun things. We're actually working on one. I don't know if I've actually told you this part yet, but I'm actually working with a company that my hope for this retreat in December is that we bring someone in and we're going to do kind of a team-building arts experience and actually possibly paint a wall in the clinic lobby. So we shall see. Still working on that one. But do some fun things and fill their cups back up because this is a lot. It's a lot on your staff and your providers, and you need to do some things to fill their cup. Team meetings are scheduled every Wednesday. We are closed from 1 to 2. Our clinic is. That's consistent so that our patients, it's like, okay, you have your provider meeting. You have the all staff, which is all staff and providers. You have the nursing meeting. You have the administrative assistant meeting. Then you have a meeting with nurses and administrative assistants together. If you have those on all different days, your patients never know when you're closed or not. If you're always closed from 1 to 2, they kind of get used to that, and of course all the signage and whatnot. The other thing we did is we have a team meeting on the 4th Wednesday of every month. So our pod, I got to get used to, we're changing more to pod than team. So we have East, West, and South. So we would meet on Tuesdays. Well, at some point in time that made a lot of sense, but what we realized was that a lot of our providers just were never going to be able to come because they were otherwise obligated during that time. So we changed it, and it's all on Wednesdays. And so then they're available, most of them are available, and they can get together with their team. We worked on a whole nother Lean Six Sigma project with HR, and we came up with a program for certified trainers. And what that means is that I have a certified trainer that's an LPN, certified trainer that's RN, an MA. We're working on all the other ones. And they're the ones that train our staff so that they're getting consistent training. And I think before, with good intentions, a new staff person would come in and they kind of hopped. That you put them with who was available, and it just didn't work, and it was inconsistent because we have staff do things very differently. The other thing is because they get this training, which they're going to get October 31st will be the next round, they get a lot of training in how to teach, how to be a good role model, and how to really teach people and let them demonstrate back to you, and some of those skills that maybe they would not have had. We've developed checklists, and that's a skills checklist that we use for orientation. We work with every single, like our x-ray, our lab. I actually have some turnover in my x-ray, which is one person in a clinic like that. So our x-ray person, she's going to go through and really update that checklist for me. So if things have changed since she's been there, I know that when I bring the new person in, if she's not there, unfortunately, I'll have that checklist to help train that person. And there again, just looking for that consistency. We've developed an online system for cataloging workflows, policies, and procedures. And in our case, that's SharePoint. I don't know if that's familiar to anybody, but there's a place that you can get into, and all that information is in one place, so that you're not, there again, we have, this is a shared folder for competencies. This one's for orientation. This one's for the checklists. This one's for policies and procedures. It's all in one place. We also have done some training with the teamwork and agenda setting training, and Dr. Littlefield has done that training. That's setting the table, getting ready for that visit. We've talked recently about doing some more of that training. We've got some new staff, and that's such an important thing, especially when you're doing 15-minute appointments. You better be prepared for that visit. Lack of physical space. I'm sure this is like we're the only ones in this room that have that problem, right? Not so much. I have to tell you a funny story as far as space. We actually, we have the opportunity, like the outreach and enrollment, there's been some non-competitive grants where you could expand that team. So we expand the team, and I just keep thinking there's no way that I can put one more person in this clinic and without stacking them like firewood, like cordwood. It's unbelievable. But we recently found some spots where like the wheelchairs were, and we put a charting in there. We found a spot, and we said, our maintenance guy, Jeff, we said he'd been holding out on us because he said, you know, there's some space under that stairway up the back hallway. And we're like, how big a space? I mean, we're talking exam room here or what? No, but it's a great charting area. So he cuts this little tiny hole, like just a little gnome hole, door into it. And you should see this charting space. Because we keep trying to add charting space, and he keeps saying the fire marshal's going to come here and close us down. So it pushed it back, so it's not causing a problem. It's not causing any trip hazards. It's awesome space. So we just keep looking for it. This project here was between MFMR, which is our Montana Family Medical Residency. We have 40 residents. We mapped all available space for every single session. This was a very interesting long meeting. We mapped clinic provider schedules and residency provider schedules, looking at, okay, if you have 30, we have 31 rooms. Well, I can kind of add a little place for outreach and enrollment. Some people can kind of move a little ways away from the clinic. But as far as exam rooms are your exam rooms, right? So we went ahead and went in and looked at it, and then we looked at their templates. We looked at our core clinical templates. And when I say core clinical, that's our mid-levels. They're not involved with we all are involved with the residency, but they don't go off to the hospital and teach residents, things like that. And then our anchor docs. We have a doc on each team that is our doctor and more involved with us than the residency, if that makes sense. And we anchored their schedules. So it's like, okay, I always know, except if we need somebody at an outlying clinic, that this person's going to be here. So we put them in. And then we looked at the residency schedule, and then you look at your pharmacists. You know, if you're bringing pharmacy into your clinic, they have to have a place to see patients. Behavioral health, they have to have a place to see patients. You can't just magically, when you start seeing people, talk to people in the lobby, you got a problem. That's not good. So we looked at all that. We looked at the number of people. If you're a provider in our clinic that's a mid-level or an anchor provider or a faculty doc, you're going to need 3 rooms. Because you tend to have a little lower no-show rate, and you're going to be, for a good clinic flow, you're going to use all 3 of those rooms. Your first-year resident who's going to see 3, maybe 4 patients, probably they don't need 3, but they should have 2. If you put them in one room, they're never going to learn how to get that clinic flow going. Like the nurse is in this room, I'm in this room, vice versa. They really need to learn that. But we use it so that we make sure that there's enough rooms for everybody to have. So for like if we have 10 providers in session and they're all anchor docs, they're going to use 30 of those rooms. So then we're going to get creative with pharmacy and behavioral health and all those things. But we've really mapped it out and looked at it so that we can get as many providers in as we possibly can. Now, when I say that in certain environments, I sound like a bean counter. I'm not a bean counter. I make sure people know that. I am not a bean counter. I'm talking patient access. If I can get providers in clinic, that means patients can be seen by their provider. And the continuity of their provider, not just any provider that's available. Clinic-wide transition, May 4th, 2015. Who can guess how we celebrated that? Close. I think we did one day every week that week, because this is the day we went to 15-minute appointments. May 4th. May the 4th be with you. We had a May the 4th be with you party. Yes. And then every day that week we did some. I think the last day was that survivor show party, and they got little packets on how to survive and made it fun. And kind of, I mean, they weren't big rewards, they were just fun little things, but just kind of lightened the atmosphere a little bit. Because you can imagine as we move towards this, people were getting a little nervous. Although the people that did the second pilot, Megan, she did the first pilot for months, and she said, I won't go back. And I'm like, yeah, you're awesome, and you really believe in this, and you saw the process. So then the next group comes in, and these are mid-level providers, a few of them I can think of. They were so skeptical, but they said they'd never go back. So by the time we went to this, we were just going, we got this. We really planned this out well. We are ready for this, but there was still a lot of nerves about it. So big party on May the 4th be with you. Okay, now this is one of those charts that if you ask me to explain this chart, I'm going to quickly turn this little gizmo right over to Mike. He is our data. He has made me a full believer in data. When I hear about problems, so often it's infrequent but memorable, and they are so upset. And you say, does this happen? It happens all the time. Well, it feels like it happens all the time right now. But sometimes you have to look at the data and go, does it really happen all the time? Not to say it's not a problem, but we need to figure out, it's like, how often? Like our IT problems, guess what? It was happening, the circle of death was happening all the time. They weren't exaggerating. So, but if you look at this chart, I didn't skip one, did I? Nope. Okay, if you look at this chart, and look on the very bottom in the blue, this is talking about our productivity. We shifted during this time from November 13th to July 5th, November of 2013 to July of 2015, from 7.6 to 8.6 patients per session. So our goal is 9, so that's pretty good. Now, you think, oh, that's one patient. Well, for that one patient, that's pretty huge. And that's times 10 providers in a session, and then 10 the next session. That could be 20 patients a day that you're getting in to see their provider. Patient to patient by, oh Lord, Mike, where did my...
Click the next one.
Oh, thank goodness. Wow. Of all the charts, I seriously thought I had a psychiatrist doing an ink blot or whatever that test is. That one got me. Okay, so this is a beautiful data chart. And it shifted from 16.6 down to 12 minutes from the time our patients walked in till they get to the provider. And I have to say, as a little side note, as I'm a nurse, I've been a nurse for a long time, and I supervise a lot of nurses. You have to remember, as lovely as we have awesome nurses, we have awesome front desks, phones, they are amazing. And our patients really just get to where they just adore these people, right? Because they get really close with a lot of their patients. But the fact is they come to see the provider. Because I am not going to be able to get them the testing they need. I'm not going to get them the medication they need. I don't have that ability. I can't write scripts. So we have to get them into that provider as soon as possible. I kind of call it that golden time. And that's what we all work for, is get them that golden time. So minutes are huge. So from 16.6 to 12. Interestingly enough, we still have work to do on this, but we had a shift from 27.73 to 31.28% of charts locked the same day. So that was an improvement. That was kind of shocking, I think, to most of our, I think probably especially our providers, because they don't expect when you tell them you're going to 15-minute appointments, that's not going to improve the chart locking time, right? But it did. There was some shift. And then we shifted with, yes.
I don't understand what a locked chart is.
Closed out, all documentation's done, scripts are sent, referrals are made, and the doctor's done. And then it would go to billing.
Okay, the locked chart to me is somebody else can't ever get into it.
That's true too. That's true. If you lock a chart, you would have to unlock it, unless maybe fiscal or billing was able to, but you truly are locking it, so nobody could go in there and add to your documentation.
Okay, they're all done.
Yes, they're done.
Okay,
They're done.
thank you.
Which means they can be billed. You know, back in the day, and this was quite some time ago, our billing, it wasn't as good. And our patients were waiting too long to get their bills, and then they're mad. You know, when they go to the doctor and a month later they don't get a bill, they're like, oh, well, I must have been right at that time. And they don't get a bill 3 months later, and then they finally get it, they're mad. So the sooner we can get them billed, the better. They're happier, it's a good satisfier, if you can imagine, for our patients, and then it's better for our clinic because we need that revenue coming in. We also shifted from 50.46 to 54.21 charts locked in less than 2 days. So maybe not same day, but in less than 2 days. So something we're going to continue to work on. And I talked about this. The biggest fear was the increase in productivity and a reduction in appointment slot time would adversely impact chart locking. And this would have been their statement at that time, that we know this is what's going to happen. So it was great when the data pulled out and said, actually, it kind of improved that. So that was good. One thing I I like a lot of things about Lean Six Sigma. I've been in quite a few different projects. I really fully believe in it. I think that the resources, the tools, the guidance, the facilitation, it's made changes that we never would have been able to make on our own. It brings Megan and I to the table. We sometimes will be, we were in a meeting the other day and we're seriously like answering each other, like finishing each other's sentences. Because you spend so much time working on improvement, you start kind of thinking the same. Mike was our facilitator for this project, and he was so great about keeping us on track. He's awesome with data, but he never told us what the answer was. Because we had to figure it out. And we had to bring in our staff. You know, we sit here and we're going to present this information, but it was way more people than us. We represent everybody that works in that clinic. And we represent many of them that came to the table for this stuff. But Mike never told us. I think there were times I looked at him and I thought, you know, because he shadowed down on the clinic so much it was unbelievable. So he kind of knew where we should go, but he always let us figure it out. But one thing I really like about Lean Six Sigma, that the PDSA, I don't feel, at least the way I was using it, didn't have as much of, and that's a control piece. Because you need to make these changes, and then you need to sustain these changes. We're just in the middle of our PCMH, was a re-recognition, you know, after 3 years. And they don't want to hear that all those wonderful things you started 3 years ago, oh, shoot, we kind of forgot, and we didn't keep them going. You need to go back a year and show that you've been doing this and you're sustaining this for a long period of time. Plus, it's the right thing to do. It's what you want to do for your patients, right? So this control piece, I get reports and I can tell you how long it takes for scripts to go out. I can tell you turnover rates, you know, whatever project we've had. This particular one, we looked at patient satisfaction, cycle times, productivity, and then session end. When are people actually done and out of session every day, morning and afternoon? And it always tells you who is going to monitor it, you know, where that report is, where that data is, so that you can look at it every month. And at what point do you react? Because you react to every single data point or data you get. You really can't. You've got to watch for those trends. You've got to see if you're going off track, unless it's just, you know, like the train's crashed. I guess that would be a different thing. But it just puts a piece in there so that you are always watching. You're always aware, and it spreads it out. It's not just one person. As a clinic manager, I'm not going to be able to track every single one of these for every single Lean Six Sigma project we have. I can't even tell you how many we've had from the clinic. Do you guys know? A lot. I don't think any of us have had time to count. But I can't do that. There's a number of these that I do, but the AA coordinator, that's our supervisor downstairs for our front end of phones, she's watching the one with the cycle times. The RN coordinator downstairs, our RN supervisor, she's watching the ones with the e-scripts, because our RNs are helping with those e-scripts. So there's a lot of different people that are watching it. And then what our job is to do, not solely by ourselves fix it, is to be the one that says, hey, wait, we got a problem. Blow the whistle. Say, regroup, we've got a problem, we've got to do something about it. So that's the end of my time, and I'll turn it over to Judy.
Would you guys want to talk just kind of what you felt about the project? And then we'll have 15 minutes after that just to go through the testimonial.
Do you want to, I kind of probably gave mine, I drank the good Kool-Aid.
Yeah, no, I I mean, I think I pretty much said everything that my testimonial sort of up front was the fact that, we had really worked on a lot of these projects and sort of nibbled around at them, but really it was sitting down with the framework, coming up with a strategic plan, and so all of those implementations that we did were very clearly mapped out in a specific order of how they were all implemented. It wasn't like we were doing it all at once, and so it was really having that being intentional and having a strategy of an approach to implement all of these changes, and having the support to kind of keep us on track that made this whole process possible, really. So.
Questions?
How did you adjust, if you did, your scheduling and the whole flow for ICD-10 on October 1st?
So we
You can have that one.
We had another. So we actually, as I was working on this and also thinking about ICD-10 for the last 2 years, I said I can't do ICD-10 in addition to like all of these other projects. We really need to make this a Lean Six Sigma project. So it actually became it became a Lean Six Sigma project and we didn't have to adjust any templates at all. We worked on ICD-10 we started, and then they pushed back to time, and so then we stopped, but really, how long would you say
When I got pulled in was about a year ago.
it was about a year ago. So we have been working on that for a full year. Again, developed a very clear strategy on how we were going to approach it, and we did not have to reduce templates at all. And it has been going. Honestly, we had built it up, and that day, Mike said he came down to the clinic and, expecting it to be like chaotic and crazy, and it was literally as if nothing had happened. And so, yeah. So I don't know if that answers your question. I think it's another testimony to how Lean Six Sigma can really help with a change that requires so many different pieces, because we had fiscal involved, we had IT involved, we had providers involved. Who else
Family
was?
health services,
Yep.
public health for immunization.
Right, other parts of our
Everybody
organization
affected
that were impacted, and it was easy.
It was such a good strategy, and I don't want to kind of break my arm, pat myself on the back, but the team.
You can break
this
your
team
arm.
did
You
such
deserve
a
it.
great job at it that outside organizations were able to leverage some of the work that we did. So for a small, a minuscule fee, we've actually provided some of the conversion tools that our IT department built to other. We have, in the last month, we've converted 400,000 different problems off of the problem list and future order sets. We did 400,000 of them over the last month. 86,000 more for RiverStone Health, and it was all just by writing a script. So we had a script that we wrote. So all we did was overnight we put the script in for anybody who uses ECW, and outside organizations were able to leverage the same thing that we did. So.
It was pretty unbelievable. I actually didn't feel well that day, and I woke up. It was just a cold. It wasn't anything too drastic, but I woke up and I thought, oh, this is not the May the 4th be with you. This is the medical apocalypse that I've been looking forward to for 2 years. And, I know they're really waiting. And I wasn't really involved as much in that Lean Six Sigma project as much as I have been in others. And so my job was to worry. And so I went in the clinic and I walked through and I was, where is everybody? And this nurse looked at me like, they're working. I went, oh, okay, I knew that. And it was unbelievably not a blip.
We're still
Not a
getting
blip.
phone calls at the end of last week from outside organizations saying make the pain stop.
Yeah, not a blip. Unbelievable. Yes?
So we actually leveraged your tool.
Oh.
We did a really poor job at planning ICD-10, and at the last minute, Daniel called us, and we kind of had this similar experience. So thanks for all of your hard work. Because it was extremely helpful, and now I know kind of what my input is great.
So we actually did some of this and used some lean things to try to do it. And the issue that we had when we were mapping out sort of this whole process from rooming the patient all the way to the patient leaving the building is decide what's the way we're gonna do this, how do you overcome the sort of clinician resistance to, I have my way of doing things and I learn my way and it's hard, it's, one of our behavioral health people compared managing staff to, keeping the butterflies in the wheelbarrow, and that's how it feels.
Yeah, yeah, it's a challenge, and I mean, I can't say that we have that completely figured out. Like I said, we have 40 different providers, and so trying to convince 40 different providers to all do things in a similar fashion is really challenging, and I think that that's where having that interdisciplinary team really is important, because it's not just Carol and I deciding that this is the best practice and this is what is working. It was their peers who were at the table, who were giving their input, and who were creating this system. And we continue to have conversations, both in our medical staff meetings and our all staff meetings, about the importance when you have 40 different provider teams. And lots of part-time providers, how important it is that we're doing things in similar ways, when we remain open to feedback. And so we are constantly getting feedback from people suggesting changes. We have a patient-centered, it's called our patient-centered medical home workflow group that goes through a lot of those suggestions. And so we hear it. But then we're constantly reinforcing that we have to have similar practices to make the system work. If every pilot decided they wanted to turn the plane on in a way that made sense for them, you never would have gotten the safety, safety to where it is in the airplane. And we talk about that it really is partly a patient safety and a quality of care, issue.
Can I add something else for that? I think one of the things that is really important when you're trying to get people on the bus, and that this team did really well, is they built a lot of credibility along the way. So, Megan stepping up saying, okay, I'm not sure this is going to work, but I'll try it. And then other people going on. The whole team just built credibility all along the way. So they started with little things, made a difference, followed through, said what they were going to say, and people just began to say, okay, I believe it. And they kind of were willing to hit the I believe button a little bit more after that.
I'll add two quick things here. Refining the scope was probably one of the best things, and we didn't really get real in-depth into it, but if you remember the problem statement, we talked about chart blocking and a goal of what we wanted to get at, which really we didn't meet. That's going to be our next project. We refined the scope of this project because it was just too big. And then the second thing that I would say is, when you have the issue of, is everybody going to get on board, make change happen, is what Brian's always told us. Are we going to get it right the first time? We may not, but like Judy said, hit the I believe button. Let's make change happen, and then we'll come back and we'll see if we miss any critical inputs as we're making change happen.
Can you explain more the session end time? Like how, was that just self-reported by the provider, or how's that defined and measured?
So,
What was the data point on this? The session ends, so like how we would know when people were actually done for the day? Is that what you're asking?
Yeah, so it
Or the
seems
session.
like that's a provider satisfaction measure, like how quickly are they getting out to lunch or the end
Right.
of the day. So did they just jot down on a piece of paper what
So,
time
and
they
Yeah.
finished?
that's going to be part of the challenge as we move forward with control planning. So a lot of the data capture was very manual.
Right.
So we're going to continue doing it manually. So we have sheets that we hang up on the doors, and people write, hey, here's what time the nurse entered the room, here's what time the nurse left the room, here's what time the provider entered the room, here's what time the provider left the room. So we have an end of session as well. So we're trying to figure out a way with our IT department to get it so that it's more automated. Because it is, right now we can only do samples.
right. And we also have, at the end of every session, the nurses. So one change that we made that we didn't really talk about was we actually, it used to be that we had nurses who just would be the designated lunch nurse that would stay over. So as a provider, when you're running behind and then all of a sudden it's noon and your nurse disappears, and then it takes even more time to get out because you all of a sudden don't have the support, and the same thing would happen at 5 o'clock. So we actually made the change that the staff who's supporting the provider has to stay until the provider is done. It is a team effort to take care of those patients. And we ended up having to pay some overtime initially, but that very rapidly went down. And so we have a checkout of when everyone, so we know, because I'm not clocking my time because, you know, I'm a non-exempt, or I'm an exempt employee, but my LPN is. And so we know exactly when she is clocking out, and that's when the session's ending.
We truly got to the point with that where that final push, and I'm a nurse saying this about us as a group, but if you really want to get out on time, you're sure going to help to make sure that the provider has everything they need. The rooms are stocked. You know what I mean? You're going to try that much harder because it affects you too. If you can just say, you know, I'm an hourly employee, 8 to 12, I'm out of here. And so was there a little pushback on that? Yes. But we watch the overtime. We'll pay it. It's going to cost you. If somebody gets a patient that's really complex and you're there, we're going to try to get them some lunch. If they've truly worked through their whole lunch, we're going to try to get them some lunchtime. I might even go get them lunch, whatever it takes. We'll pay the overtime, but that's infrequent but memorable. Mm-hmm. It's usually just a few minutes, you know, and they work really hard together as a team to try to get done. Yeah, and as a provider, when we made that change, all of a sudden, people were like coming out of the woodworks when it was like 30 minutes before the set. What can I do to get you out? What can I do? Like, and I mean, it helped a lot to make sure that instead of everyone starting to, you know, look at the menu about where they were going to go for lunch, all of a sudden everyone is like on board to get everyone caught up by the end of the session.
I was curious, so we have gone from 4 10-hour days back to 8, 8 5s, 5 8s, not 8 5s, 5 8s, and we had a lot of pushback, but we think it will serve everybody better, because what was happening when we had 4 10s, if somebody doesn't show up for work, you're really kind of down an extra FTE.
Yeah.
So I'm just curious what your schedule for particularly your MAs and nursing staff is.
Most of them work 8 to 5, Monday through Friday. We do have we do evening clinic from 5 to 7, Monday through Thursday. So I have one nurse that covers that. And interestingly, they say that, because this is kind of new, but I just put her into a 410 shift because we are having trouble, and probably other people, maybe statewide, or, you know, other states, finding LPNs. So she's doing that to give us more sessions a week with LPN coverage. And then we have our front desk person that works evenings, also does 410s, but everybody else is on 5 8s.
Could you speak a little bit more into how you actually prep the clinic for it? I mean, I realize you hired Ager, you allocated, you found and created 2 black belts. But then how did you prep the staff in order to be able to do this? You did these white belt trainings?
Yep.
Yeah, we did. One of the things that Brian did when he came to do a readiness assessment for us is he talked to a lot of staff and said, what is it that you're going to need and what are you going to do? And we had, as an organization, probably for the 6 years previous, had done a lot of work on our culture and just a lot of work on culture about improving customer service. And so staff were pretty engaged in a lot of that. And so with this, we designated that education was going to be important, training was going to be important. But probably the biggest thing, and we're going to talk a little bit about this, is that when we started choosing projects, they were just not projects that were going to have financial impact. Because we are a very mission-driven organization, as I'm sure most of you are. And we knew that if we went to our staff and said, okay, the only reason we're doing this is so we are going to cut this much out of our budget. And we knew that wouldn't fly. So about half of our projects that we do have no financial impact. They're just the right thing to do. And so we wanted to make sure that we balanced those for staff. And we wanted to make sure that the communication was open for staff, that I've got an idea. Great, what's your idea? Let's listen to it. We included them in the project teams, making sure that everyone's voice was heard. And for a lot of our staff, that was the first time ever that they had been asked their opinion. But well, what do you think would be better? How do you want to improve that? So we did all of those things. Am I missing anything?
For our white belts, my yellow belts.
Yeah, so we do, the white belt training is a 2-hour training. It's the foundation of what what Lean Six Sigma is. And we've had almost 85% of our staff go through that. And what people are looking at, what our staff told us that they wanted the opportunity for more professional growth and education. And so they really are viewing that as an opportunity. The Yellow Belt is about a 30-hour training. So people are viewing it, and I guess I don't want to speak for you, but they're kind of viewing it as, oh, okay, I've got this. And it's just, then they started seeping it out to the rest of the organization. So it was really grassroots. As far as making sure that, now I had been in the organization a long time. Mike was new to the organization, and you know, it worked. Our staff embraced it. So.
And I'd say our staff, the opportunity to work on a committee and be seen as a peer with people that maybe were intimidated, you know, hanging out with the managers or sitting with an MD and saying, well, I think it's this way, is hugely empowering to your staff. I mean, I think it moved our patient-centered medical home, our care teams along a lot, to have people that had done some project work and kind of went, oh, that's what you guys do when you're sitting there pushing paper all day.
Yeah, having all the fun.
But it changed kind of the dynamic for everybody.
And I think that having the outside facilitators actually, I mean, there are staff, but not, so for the clinic, not being either Carol or I really actually helps. You know, very often providers kind of take over the conversation. You know, I mean, you would have, you know, previously we would have a group of people, and it was like the only people who would talk would be the providers because they tend to be very opinionated and they have a lot to say. And our AA staff, our administrative assistant staff, would not say a word, you know, because they're not going to disagree with, you know, the provider. And so having an outside facilitator who's not in the clinic sort of run those groups, and also try and keep some of the physicians and, you know, or some of the more stronger, more vocal folks in check, and making sure that everyone in the room has had their say, I think really, you know, really helped.
And it just got better over time. You know, they now, I mean, you come to a PCMH meeting at RiverStone and you get somebody from the front desk telling you what's up. and that's good, because at first they were pretty quiet. And so that took time, and we had to have a really, Megan and I especially, because there were a few of the early meetings where I realized that we were the ones talking. And it was worse if we weren't on the same page, because then it's like, nobody say a word.
Mom and Dad fighting.
Yeah, they're gonna fight. It's like, no, they're not. I mean, because we were so used to batting this stuff back and forth that it didn't faze us to maybe see it from a different perspective and to voice that. But they were just going, ooh, this is kind of crazy. And then you have meetings in different conference rooms, and sometimes they're not available, so you put them in the boardroom, and they're up in the boardroom going, oh, what am I doing here? And we had to kind of get over that. It's like, come to the boardroom, grab a pop out of the fridge, relax. We want to hear what you have to say. And they're there. They like being part of it now.
How long did it take you to get there with the culture?
I'd say probably this last year. Would you?
Yeah, I'd say probably a little over a year. You know, when we first started, it was a lot of push, right? So we were pushing projects out. So here's what the leadership team decided were the projects that we're going to prioritize. And now we've got a lot of pull. Like, we don't even have enough resources to keep up with all of the requests from
All of the
We
ideas.
really don't. So we like have a project list where like ideas come in, we put on the list, we rank and prioritize, and then we go and over.
So it took you a year to affect the culture and get it to this point.
It was a
I
culture
would
to
say-
begin with, like Judy.
Yeah, it really was. I would say probably in that first year, it took to the end of that first year to feel like everybody was pretty comfortable with it. And now they're so comfortable with it. You know, if somebody comes up, you'll see one of the projects that one of the nurses came up with in the clinic. And it used to be that I was involved in every single project, but you can imagine, and this got really long. And so I kind of had to prioritize. And now it's like, if you come up with a really good idea and you've trained and you've got your white belt, it's like, represent us, you know, do that, get on the list and go for it. And they just, that has been awesome. They love that. They love to see their idea, you know, come to fruition. They've remodeled the medication room, they did the supply room, you name it. They come with ideas. So
We make sure we also celebrate the successes. So 3 times a year we do what we call a report out. Again, we invite the board, we invite all the staff, we invite everyone, and we provide lunch, which helps. But I can't believe that they just come for the Subway sandwiches. And they watch their co-workers present projects. And for a lot of folks, it's the first time they have ever been up in front of a group. And they may say, I don't even want to talk. I just want to stand up there with you guys, but they're part of the team.
And I think it was probably, I mean, and I wasn't around when RiverStone contracted Aviator Group, but I think, Judy had talked to the slide about the maturity scale. And I think that's part of what a consulting group brings is that kind of planning from the upfront to say, here's how we're going to get your organization culturally ready for this, and here's how we're going to get to this point. And really like how we handle a project, they handle the deployment, right? They say, here's this prescribed method that we're going to use to get you where you need to be.
We did L6S project just the way you guys did. We call it patient flow, and we have done 2 projects. We've got 1 more to go, which is the empaneling care team part. And I've been doing L6S for years, and in this position I can't do it. So we hired a company to come in, and we just did the AAR on that after action review. And the biggest thing is they didn't attend to the adaptive change piece. And so it left people frustrated and scared and angry. Though the experiments that we did, the whole clinic just calmed down. Our template is completely different than yours, but we use scribes. But they liked it a lot, but a lot of uproar in getting there. And so now we used to do the John Cotter adaptive change work. And so now we're infusing that and making sure that that's part of it. But it was upsetting in the beginning. They recognized the benefit, but it was a rough road getting there.
What Mike and I say a lot of times is the skill that we bring to the table is managing the personalities, because there's always oh my gosh, this is the worst day of my life, you are changing the way I do my job. And so a lot of that is just, as a neutral player, we're able to help move people along that road. So we will be happy to stay afterwards if you guys have more questions in regards to specifically the clinic efficiency project or for Lean Six Sigma. But the next part of it is giving you something to take home. So we'll go ahead and get started on that.
Okay, so the last learning objective is how to deploy Lean Six Sigma within your CHC. So we'll talk a little bit about project selection criteria, project ideas, identifying barriers, to overcome those barriers, and then we'll get you started on writing a problem statement for one of your projects. So, a bunch of projects. We told you one that's very complex today, but they range all over the gambit. We did things as easy as just finding a company to partner with for a buying group for our medical supplies. So Brian, our consultant, also works at Billings Clinic, who's a big organization, and they have a buying group that they use, and they have a parent-child relationship with a bunch of other little organizations. It helps them get prices at a better price, and then it also helps us because then we get their price instead of our price. So as simple as signing an agreement, we were able to save $15,000 a year, right? Up to bigger projects where we talk about increasing home care productivity, decreasing bad debt and first-year turnover, where you're talking about $150,000 plus per year that you could have an impact on. And I'm surprised nobody asked the question about this project, so I'm going to surprise these two because they haven't heard it yet either. But our fiscal department just finalized our financial impact for the clinic workflow project. It's $203,000 per year. So yeah, so they did a great job. So it's pretty big for them, and they did a great job. Okay. So how do you decide which ones of those are you going to work? Which ideas are going to be the best ideas that are going to rise to the top? So like Judy alluded to, what's important in your organization. For us, we're very mission driven, so it wasn't just about the bottom dollar. Lean Six Sigma has a lot of background in manufacturing, and so for them, it's typically about how do I impact the bottom line. For us, there were other things that we looked at. So the first thing that we asked ourselves is, does the project fit with our mission, vision, and values? Because anything outside of our mission, vision, and values is not worth us doing. So if it's just about raising money, our CEO is famous for saying, if we need to raise some cash, all we would do is we'd put a liquor, tobacco, and alcohol store right in the corner of our parking lot. We can make a ton of money, right? But that doesn't align with our mission, vision, and values, right? So everything that we do has to align with what we are as an organization. We ask ourselves, will it positively impact our patients or clients? If it's not, if it's going to have a negative impact, we won't do the project. Sometimes we do projects that the patient doesn't even feel, and that's okay, right? So if it's just the right thing to do for our organization because it's going to make things better for our staff, we'll still do it as long as it doesn't adversely impact our patients. Which brings us to our next one. Is it going to positively impact our staff? Again, if it hurts them, we're not going to do it. If it's neutral or better, then we'll consider doing the project. And then the last one, will it result in a positive financial improvement? And so again, like Judy had said earlier, about half of our projects have a financial improvement. The rest of them, we do it because it's the right thing to do for our staff and for our patients. So that's something that you guys will have to look at as you do it. We actually have some pages on here that we're going to do a breakout session in a little bit where you guys can brainstorm a little bit more about maybe what are the right project considerations for your organization. Identify potential projects and barriers to the project success. So how will you overcome the barriers? So really what we want to do right now is take time at your tables, and we want everybody to say, if I wanted to implement and deploy a Lean Six Sigma initiative at my organization, what's stopping us from doing it right now? I want you guys to brainstorm together. What do those things look like? You have some pages in the middle of your table if you guys can disperse them so you can take notes to take back to your organization with you and say, here's what's stopping us from doing it now, and then brainstorm together how do we overcome those barriers that we come up with as a group. And then at the end of, we'll give you about 10 minutes to do that. At the end of it, we'll ask each of you to have one person to give a quick 1 or 2 minute discussion about what your group came up with. Any questions about that? And we'll walk around to help answer any questions as you have them. Okay?
I was asking what the $203 was. 1,000.
Yeah, so that's all of the productivity. Yeah, so all of the stuff that we added, if you remember, was already in the budget, or you got a grant, and or we did a shift. So all of that stuff was already budgeted. So we didn't want to pass it like that.
So how do you feel? I think it's gone really well. It's like a good rotation. No, I get it. You know what I mean? Yeah. Even if thank you guys. I think you added a lot of credibility and a lot of this is how it is from us.
Yeah. Well, it's like adding a big testimonial to it.
Yeah, it is.
It's good.
Appreciate it.
Yeah.
It's fun to hear your information again. I know we've heard all that, but I still like it. I still laugh at the actual feature things.
I know, so do we. We watch it once a month. It's ridiculous. It's like we just turn them on and stuff. talked about our spouses. You have absolutely no idea. And it's exactly like that. When eyes glaze over.
If she asks how your day was, I tell her good or bad. And it's always good.
We can give each, that whoever presents from the table can get a phone,
Okay.
right?
Yep.
Whoever's the spokesperson.
Yep.
So there's an incentive to be the spokesperson.
Yeah, we have changed to access. So we put a ton of work into it where Institute for Healthcare work on
Yep.
Twice a day.
Yeah.
There's more people here.
Is there? Is there? Evaluations. You don't write anything down.
I can just take notes of figures. About 5 more minutes. Try and pick the number one barrier and how to overcome it from each table.
they have advisors. We were, they had a special collaborative.
Do you want to do the problem statement since I took this one?
I'm okay if you take both of them,
Oh.
if you want to. I did a lot of talking earlier, so I would like to share the wealth if you're okay with that.
I'm actually shocked at the number of people that came. Not that I should be, but I was just, I know.
High five. We still deserve a good meal tonight.
I was fully expecting it.
I know.
But
But you know,
at
on
least
one
a
hand,
quarter
I
of
was
the people.
I was afraid of that,
Uh-huh.
but on one hand, I'm like, this is such good stuff.
Well, I thought so too. And I thought it worked out good that they didn't hear like the result before they left.
Yeah, that actually worked out pretty well. No, come back and hear Carol talk about what happened.
Yep.
So we want these to the speakers, or
Yeah, to the one person that presents from each table. Okay, start wrapping up and pick who your speaker's going to be, and we'll go in about a minute. God bless you.
Take control. So it's for good. So we've got.
We have enough time.
You're fine. You're within a half an hour. You're excited and you're passionate.
And start cutting slides. That's really
No thank you. Okay, let's bring it back in. And is there a table that would like to volunteer to share their top barrier first? Or project or barrier that you guys came up with. You get a sweet thumb drive if you go. You guys want to go? I hear you guys want to? You guys want to go then? All right, I see a hand, so we'll go over here first.
We'll get it out of the way.
Thank you.
So we had a discussion, we're all in various EMRs, but we have similar challenges. So our overall problem statement is within EMRs having incorrect or unavailable reporting. Reports. The impact on that touches everything. I mean, you have to do scan chart audits, for example. I mean, you're having increased productivity, you're increasing cost. I mean, downstream you can have, negatively impact your UDS numbers, have a poor, whatever the case may be. So our desired goal is to have accurate, attainable information reporting. And primary ways targeted by the project. I would go with time.
Good. And what's your biggest barrier to getting that done? Cost. And how do you overcome that barrier?
Well, I know the one thing we're trying is we sent a couple of our IT and another staff member who's going to do more database to special training to learn more on EHS in case there's more there that we just don't want to use.
Exactly. We were actually going through the same process similar with our pharmacy. We use QS1 in the pharmacy, and by use I mean kind of lightly, we use it because we don't know all of its full capabilities. So are there things that are available that we're not taking advantage of that we can, and it's already free? We're already paying for QS1, right? So that's a great idea. So good idea. Good job, you guys. Who else? Who wants to go next? Barriers and or project ideas. Or I'm going to pick somebody. Nobody likes that. All right, how about the back table? Who wants to go?
I'll just kind of speak, I think we were talking about just general things that, when you look at all the scope of a project, I think the barrier from what we're trying to do is really trying to figure out how to get that focus to really do something instead of trying to, because as you start to unpeel the onion, it's like, oh my gosh, and then you've got like all, what you were saying earlier, all these like little rabbit holes that you go over here, and then you go, now where do we start? What do we do again? I mean, that's, I think, so we're trying to really figure out how to get that roadmap a little more clear. We know where we want to go with the patient experience redesign, but then how do we get there very systematically? And so, I think for me and others, that's a huge barrier, is trying to keep bringing it back to something that you can focus and do. And what you said earlier, change something, move forward, as I call it, fail forward, do it, get right back up and keep moving. So.
And we call that scope creep.
Yeah.
And the great thing about, we'll have you do a problem statement next. The great thing about a problem statement and some of the tools is that people will say, oh, well, we also need to do this, and we also need to do that. You go back to that problem statement and say, is that what we wanted to solve? It could go into the parking lot and we do it the next project. But scope creep is like a death knell for some projects.
It's a good idea. Thank you for sharing. Yes.
We talked more about the barriers that we have, that we all thought that we would have in terms of bringing in a
And how do you overcome that?
That's a tough one. I mean, you try multiple ways to, work with them to get some buy-in, but some folks are gonna be maybe set in their way. It's always worked this way, and I don't know how you get over those bigger ones where you just have a high-ranking individual maybe, or an outspoken individual that is just set, and people seem to follow. So, I don't know, maybe until they move on.
We did have some of
Bad
that.
business, right?
So for us, a lot of the things that, like a lot of the tools that you use, like when you use a process flow map to say, here's how we're currently doing the process. So the people that get stuck in their ways, when they see how we're actually doing it and the variation within and between the people that are doing the process is the biggest eye opener. So as you run through and using the tools, those people who are initially look like they're not gonna be supporters and they're gonna block your success, see it real quick because it's very visual when you see, man, 52% of our process steps are with the provider, right? So then other people that may have said we can't offload some of these duties onto somebody else, we're like, wow, I get it now, right? So it's just the process works. You got to hit the I believe button and go through the process. It really helps transform you culturally. So.
And you need to have that data that you're just
Yes.
talking about, and people with the skills to take that data and present it in the right way, so these other individuals will, the dots will connect and they're gonna get that realization, that aha moment.
Yep.
So those are important parts to staff accordingly.
Exactly.
Well, and one of the things that in our organization, I said, our president and CEO was like, this is what we need to do. And so it came from him down to senior leadership, and then that came out, to staff. And so people, I don't mean this in a bad way, but people didn't realize it was an option, and it was like, okay, let's do this. This is what we're doing as an organization. And our consultant often says the biggest challenges are if the initiative comes from middle management and you're trying to push it up and down. And that really is a no-win situation.
Okay. The two front tables. Who wants to go next? Yes, thank you.
We talked a lot about improving access to the clinic, and that's a challenge just because it's so broad. It's a really huge project, so that we're having trouble with the scope on that one. But someone else had a smaller subset, which I think was good, was like how to modify the own internal demand that your own providers or clinic is generating for appointments.
Mm-hmm. And what are the barriers to that? Is that just variation? Like different people have different requirements, or?
Yeah, it's mostly just variation.
Yeah.
Trying to get standardization
Mm-hmm.
for all of them.
Mm-hmm.
Some physicians tell their patients, I want to see you every month or every week,
Mm-hmm.
and that has a big impact on access. So how do we manage that?
Yep. We go through some. We just had a meeting last week about same thing, access issues. So it's definitely a very good project idea. So thank you for sharing. What about this group? Save the best for last.
We talked about barriers and kind of listed quite a few, and then thought it's a wonder things get off the ground at all.
Uh-huh.
And then we were looking, I guess, a little bit for what themes we saw, barriers we were listing, and it sort of comes down to that keyword of time. Do you have staff with time? Do you have time to train? Do you have time to block out schedules and have meetings and spend a half a day on process mapping? Time to roll it out, time to follow up and manage it, and all of that kind of stuff. It's sort of, we're in such a changing environment with healthcare that there's already a bunch of projects without picking a bunch of new ones and adding them in. And so trying to prioritize what ones are really gonna help instead of just sort of add to the noise we already have going. How do you figure that out? I think some of the thoughtful ways of picking projects that align with the mission, where you're feeding people's soul because, hey, this is a really good thing to work on and I see the benefits to the patients, and picking things that in the long run are going to improve processes so that the pain was worth it, instead of we got the ball to the 3-yard line and then we drifted off to this new project.
Thank you for sharing. Okay, so the last thing we're going to do then is we're going to try and write a problem statement. So the middle table over here already got a good start on there. So we're going to give you a quick example of a problem statement. 15 minutes. Okay, so here's a quick example of one of the first projects that I helped work on. dealt with our behavioral health team. And so really you have this on your sheets. You'll have what's the problem statement, which is the top piece, what's the impact of our problem, what's the desired state, and what's the waste targeted. So when you write the actual problem statement, typically we like to base it on data. So a lot of times we say based on data gathered between, you don't have your IT people here or your analytics people, so it's a little difficult, but you can say, a lot of times the way we start when we don't have data is based on data gathered between X and Y dates. We found that we had Z number of encounters per FTE in fiscal year 2012, right? So you can just put in and go get the data later. And then you want to compare it to something else. So why is it bad? Why is that a problem in your problem statement? So is there some sort of benchmark that we're trying to hit against? Is there an internal standard that we're not hitting, whatever it might be? When you write your impact, you want to say, who is this impacting? And a lot of times we bullet point this. You can do it whatever way makes most sense to you. So is it impacting our patients? Is it impacting us fiscally? Is it impacting our staff? What's the impact of the problem that we listed above? Your desired state is where do you want to be specifically? So your shift change in performance, maybe a percentage, maybe an actual number. And the one thing that you want to pay attention to is you always want to pick a desired end date. So when do we want to have all of this completed by? Because otherwise, it's never going to end. And then primary waste targeted. Who remembers the acronym for the 8 elements of waste? Tim Woody. So you want to pick out what types of waste are you targeting in your problem. So as a group, you guys can do them individually, or you can pick a group one if you guys came to a consensus about a group project and just work through these. If you have questions as you're working through your problem statements and the charter, just raise your hand and we'll swing by and help you. So we'll do about 10 minutes. We'll have one person that'll kind of give us a report out on how that process went, and then maybe you have something to take back with you at the end of this trip.